Welcome back. Just took a short break. And we are back with Dr. Elliot Fisher. And we're sort of moving into sections 4, 5, and 6, talking around hospital budgets, network oversight. And we've invited you back because you're always filled with enormous amounts of knowledge and things.
The energy, maybe not.
Things we should be thinking of.
Yeah.
Move through this bill.
Yeah. Well, thank you. It's great to be here. I did finally read line by line the bill last night. As I suddenly realized, I have to be there tomorrow morning and there might be questions. It's not all in my head yet. But I'd like to start with a couple of general comments, sort of on where I see us sitting right now, because I think they set up why and how we might think about further revising the legislation. I also can't resist having gone through a comment on section 1 and a comment on section 2 and a couple of suggestions on section 3. As we go spinning by, I won't spend much time on them. It's mostly big picture, and I'll read behind. I have specific language suggestions that may be useful. I'll leave that.
Great.
Yikes. When I look at where we are right now, there's just no question we can't afford to have healthcare costs continue to rise. You know, the predicted 20% increase in premiums. We have a top-heavy hospital-centric system, as Act 167 report, and we all know. We're underinvesting in primary care, mental health, and community-based services. And we can reduce healthcare costs. I totally believe if we had healthcare costs that were identical to New Hampshire 5 years ago, that means there's a lot of money we've suddenly started putting someplace that we should be able to take out if we can put together the process and the institutions that will allow us to make that happen. And I think that's, and I've been working closely with Brent James, the Intermountain Healthcare, who is confident based on the data he's put together on his own system with the best data tools in the country to analyze the quality and cost of care. He's confident he can take 35 to 50% out of US healthcare costs if we all adopted payment models that rewarded better care and lower costs, and everybody adopted improvement methods that would allow us to achieve those goals. So, and that was before the Trump administration came in. And I think we just have to recognize just the unprecedented challenges and uncertainty that we face right now. Today, tomorrow, it's changing all the time. I think, from what I understand, both the Green Mountain Care Board and AHS are responding really constructively to this urgency and terrible challenges we face. And I think the work of S126 is to try to make possible what we need to do with any changes that are necessary to make to the law as it stands. And so I think the challenge is about granting the flexibility needed to allow the board and AHS to respond in a timely way with all the tools they need to be able to respond to this crisis. And while establishing accountability with clarity of aims and deadlines. And that seems to be the tension in this bill, the tensions between requiring things immediately and telling the board what to do on all these things and giving them a set of goals and tools that they may use with flexibility to adapt to circumstances as they change and not impose unnecessary regulations or work on a system that's already overloaded. And I've got some initial thoughts about how to do that in the bill a little bit. But I think that's going to be the art of drafting this, I'm afraid. And I'm happy to interact in ways to think about making that more useful and better. So those are, then I'll go, but the devil is in the details. and those are all of our challenges. I'm happy to, and please interrupt me at any time. I'm totally comfortable trying to
can I interrupt you
Yeah, of
really
course,
quick?
totally.
Something that you said, because, you know, both Christopher and Elena
Mhm.
had said this, in a market, a healthcare market such as
Mhm.
with small population, larger area, rurality, where we don't have the competitive market that other states may have. Do you feel as though the only way to control costs is through a regulator?
Um, Let me say, I think incentives are incredibly important to getting the performance we need out of the healthcare system. And that's not necessarily about competition. Even in non-competitive markets, if you get the incentives right, I'm confident, I shouldn't be confident about anything in the healthcare system. But I think incentives are a fundamental part of competition. It is one of the ways of forcing people to face incentives. Competition in healthcare is weird because we don't measure quality very well. And we have so many, um, we have a lot of ways that it's easy to avoid competing. So I think a strong regulator and a strong iterative learning and planning or modification of how you do things, that those can put in place the rules that make it possible for us to use incentives to reduce costs. Now, there's a lot that has to happen to make that work. And one of the great strengths, I think, of the Green Mountain Care Board is that it really was founded to do payment reform. It seems like one of its primary responsibilities is payment reform. And the one thing I don't see being talked about a lot or even included explicitly in the bill, and it's probably because it doesn't need to be there, and but I think moving to payment reforms that are very much aligned with what Intermountain has done, most Kaiser Permanente and what others do, moving toward a global payment model that creates incentives for, let's call them population health organizations, since everyone hates the term ACO, but accountable care organizations that would incentivize physicians to work together with other physicians in their region and across the state to lower costs and get a share of the savings they achieve by improving quality and improving the health of the people they serve. Does that kind of get at that? I don't think it's a complete dodge.
It's more using your regulator to regulate using incentives to provide the care.
There will be places where we probably need to set some fences, for beyond which you can't go. I think hospital global budgets, which you've been talking about, are one of those kinds of fences. Budgets or enforceable budgets, which is sort of what global budgets are, is one form of fence that says you can't go beyond this. But as I'll talk about, if you just set a global budget, the incentive is to reduce costs within it as much as you can, but not necessarily to improve quality and not necessarily to reduce costs and come back ready the following year to have a lower budget. So we would like to figure out ways, I think, as a state, and I think the Green Mountain Care Board is well positioned to do it. And the sections I'm asked to speak about today will help us talk through some of that to try to think about how to use budgets and payment reform to incentivize efficiency and shrinkage, where I'm going to use the term, we all started out with the term, what's it, right sizing? Mm-hmm. Terrible word, right? Mm-hmm. It makes everyone think they're going to shrink. Optimization, I think, is the word we should try to shift toward. How do we optimize the delivery system to improve health, improve healthcare, improve access, and improve health and lower costs? Does that make any sense at all?
Mm-hmm. Makes total sense.
Principles for us to aim for, really hard to do. So,
Leslie?
Go ahead.
Yeah, Ellie.
Yeah.
So you said move towards a global model to incentivize working together. Does that mean moving away from competition? We hear a lot about competition.
Well, you know, how's a Scotney going to compete with Springfield? I mean, or now, I think primary care practices, you know, there's a lot of work in the 90s and early aughts, I believe. Rick Kronick did on what's the size of a practice, primary care practice that can meaningfully measure quality and compete with others. It's about 30,000 people where you could actuarially do well. So I think competing 600,000, how many? It's 30. We could have competition, you know, among primary care groups within areas and across areas. I mean, you'd like to. So I think that's a place where you could do where competition might work. You know, if I had my druthers, we'd have great quality measures on major expensive surgical procedures and cancer treatments. And then we could have competition between, you know, the Boston systems where they've got 3 or 4 different competing hospitals trying to lower costs so that people can get their care from the best. You know, Dana-Farber thinks it's better than Mass General. But or we could have competition between DH and so if we had price good quality data, we could have competition on what advanced procedures or treatments you wanted to get. And they could be forced to compete on price if you had the sort of a model where the primary care groups or regional group were incentivized to keep costs down, and thus they would save by incentivizing. Elliot, why are you going to Dartmouth Hitchcock? Look at this alternative here. So I believe in competition, but you have to think about the market where it can work.
Mhm.
Could you just kind of elaborate a little bit on how competition could take place within a global budget?
Yeah, well, let me get the incentives. So first, the incentives I think can help, you know, and one of the world's, Bob Murray, who's one of the country's experts on hospital global budgets, maybe not world, just the United States. Let's not exaggerate, Elliot. So one of the reasons he believed in the variable adaptation of prices under a global budget, of payments under a global budget to account for fixed versus variable costs, is that variable costs can change quite quickly. And he's argued that if you have an ACO payment model, a global payment model for the delivery system that's not part of the hospital, that's the medical groups, for example, that if they know how to do it, treated chronic disease well, kept people who were sick out of the hospital by providing nurses and phone calls at home to make sure they're taking their medications and whatever, keep people out of the hospitals, then if you successfully, as I think you could, reduce utilization at those hospitals, their costs go down. You know, you save some of the money under that global budget and keep it back for the payers or back for the community. Does that make any sense at all, Topper? I'm not sure.
Yeah.
So getting the incentives right, the real barrier, I think, or at least the way I understand Maryland, is that their global budget system said they all negotiated with the hospital that this is our global budget. We love it. So we'll take our global budget. And then they, you know, reduced their spending within it, captured $1 billion or something in the first few years of the global budget, but kept it for themselves. And I think that's a danger of global budgets. And so this is where, when we get to the section on planning, you'll tear your hair out as I try to think about a multi-year budgeting process so that you can adapt the sizes of the hospitals to the changing needs of the community and the changing capacity of the healthcare system to take costs out. Does that make?
Yeah. My problem is I have a problem when you mention Maryland. Well, one hospital catchment area is bigger than the state of Vermont.
Yeah.
And what I'm trying to do is put myself in Vermont, and how can that work there, work here?
Yeah. Well, this is why I think delegation of the working on the details to people like Elena and the others at the board who are continually thinking and consulting about how to do it. I think it is wise to ask the Green Mountain Care Board to design the global budget process that we want to use in Vermont that's fit to our purposes and needs and capacity. But I think, hospitals are, what is it, 60% of our spending? Hospitals are a huge portion of healthcare spending.
Yeah.
These facilities are incredibly expensive and slow to build and slow to close down, although we could use some quickly. So working on a model for Vermont that figures out how we're going to have an optimized hospital and other facility. I think we tend to use the term hospital when what we might mean in some communities is a different kind of organization that's serving communities with great primary care, but only one of the several hospitals in that quality have inpatient hospital beds or emergency room. I think we have to do that redesign. And I think a global budget system could help us do that. But even just right now, getting strong, thinking about how we use the existing budget setting tools that the Green Mountain Care Board has to accelerate those changes in a sensible way that's not having everybody bid for, hey, this is the budget I want, give me 15%, and then they dicker back and forth and it goes down to 3 again. I don't think that's the way we want to think about our regional integrated hospital and optimized hospital system. I think we need to think about them. How do we get the hospitals we need in these places in a way that's affordable for Vermonters?
Yeah.
So I think we
I
can
like
do
that regional
Yeah, I think,
catchment area approach.
I think we ought to be getting them to talk to each other, gosh darn it. Well, I'll talk about that in a little bit if you want. So shall I go on and
Sure.
start? So,
Sorry, we derailed you.
no, I'm totally happy to be derailed. As you can tell, I like to talk. It's a danger. So section 1 briefly, I think articulating other goals that we might have as you think about those. There are lots of admirable ones like health integrated care. The one that I sort of wondered about as missing is something about our healthcare workforce and the moral injury and stress and unhappiness that so many are experiencing, and whether you wanted to add a goal somewhere, whether it's in the duties, because there's a little bit about goals and the duties, or whether it's in the goals, that's something like improving the health, well-being, dignity, and resilience of the healthcare workforce. Let's make them aim for that. Reduce administrative burdens, but let's have that an aim so that we're trying to keep our workers here and recruit others. Because if we solve that problem, everyone will want to move to Vermont.
Yeah, go ahead.
Can you say that again? What phrase you would insert?
I've got this for you. I'll
Hear it again?
Oh, sure.
I have a
No.
question.
So, it's improving the health, well-being, dignity, and resilience of the healthcare workforce. And I'm happy to add other phrases.
Yeah, so I think one of the issues that the healthcare workforce has experienced is being having experienced moral injury and then being expected to use tools that increase our resilience without stopping the moral
Yeah,
injury. So I think there needs to be
Right.
something in there that says stopping the moral injury in order to, because you can't really have resilience while the moral injury is continuing.
Having us all go meditate doesn't quite solve the problem.
My
Right.
point exactly. Yeah.
I do talk about the why, which is the stress and moral injury experienced by the workforce. And so I think to address I agree. Great. In section 2, there's this long list of things, but I think somewhere, actually I could open this. The bill's in my pack. But we should always mention the health of the population in this long list of things we're trying to do, like to improve healthcare quality. there's a section in part in section 3 that says access to primary, now is only focused on improving access to primary healthcare services for the underserved. And I just think everyone should have improved access to care, not just the underserved. And I'll leave these with you. In section 3, there's this place on page 7. I'm going to grab my things. I'm going to it to you. This is stupid. You will be frustrated. If my name is not a copy of the bill. And I must be sitting in the hot seat.
They all are.
What's the room?
Just briefly, section 3, page 5.
Could you just go back to where the underserved?
Yeah, so page 2, line 17. You get this long list, oversee the development, implementation, evaluate the effectiveness of healthcare, blah, blah, blah. Control the rate of growth in healthcare costs, promote seamless care administration and service delivery, and maintain healthcare quality in Vermont, including ensuring payment reform projects set forth. I think this should be about improving healthcare quality and contributing to improving the health of Vermont residents. So it's sort of capturing and I've got this all written out here for you if you want. I also don't think you should call payment reform pilot projects. They should be payment reform projects. There's a lot here that's really, really good though, by the way. This is just.
Before I rip it all apart, there's some really good stuff.
I really do believe that there's sections 3, page 5, while we're at this. There's just at the bottom of that page, methodologies, lines 20 and 21, you talk, the board shall approve payment methodologies that encourage cost containment, blah, blah, blah. And then it just says access to primary healthcare health services for underserved individuals, population, and areas. And I just think you should be including everybody. For all residents, or all individuals, population, and areas. And then I add, and the promotion of health and well-being. I don't think it's just healthy lifestyles. I think you want to have people taking their meds. Half of us don't have our blood pressure recognized or controlled. All right. Last, and I am sorry to be doing the early stuff, but it's great to be with you, so I get my nits available. Is page 7. And this is back to the topic that at the top of page 7, as I reflected on giving the board the tools it needs, but not constraining it. I think that reference-based prices established, first 2 lines, reference-based prices established pursuant to this subsection shall be based on a percentage of the Medicare reimbursement rate. And elsewhere in the document, or other.
I'm not sure. What
It's a different version.
Yeah.
Oh, it's a different version.
Yeah.
Well, apologies for that. I took the one that, so you guys are,
So can you just say what section you're on?
oh, I'm in section 2A.
But of what?
As passed by Senate.
I had those passed by Senate, so reference-based pricing, section,
Yeah.
subsection E. Thank you for pointing that
Hold
out.
on.
Right, so we're section 2.
Reference-based pricing.
6.
We have it on page 6.
We've got it.
Yeah.
So I have it, reference-based pricing starting on
Yeah,
page 6.
and so then go to
And
2A.
that, I thought that was great. And then go down below that to 2A,
So it's-
reference-based
Yeah,
pricing.
page 6, row 17.
6.
Okay, so it's row 17 in yours. There's the line that just says it shall be based on a percentage of the Medicare reimbursement rate. And elsewhere in the document, you say, or other such reason, something like, or other such reasonable standard as the board may determine. And I would not tie their hands.
Sorry.
No, not toward. So I would just think about trying to give them some flexibility or other or another benchmark as appropriate, just so that they can, down in the terrible weeds, they're not tied to using Medicare rates if we need to make other kinds of changes. Further down, which I'm not sure you're gonna.
Yeah, hold on. I'm gonna be able to help you. You just show me where you are. Okay, so
Or the board shall
then
identify factors that would
page
necessitate.
8. If I'm on the same one as you all, line 4, the board shall identify factors.
Yeah, and
Does that work?
yeah, that's, I just thought necessitate terminating. And I wondered if you just add or modifying. It just gives them a little more flexibility. It's not
Are you
a,
guys all on the wrong one
I'm
too?
on a totally different.
Okay,
version than.
And I'm
I have
on.
it, so.
I got it, I'm going.
I'm on as past the 7.
I'm sorry.
If you need any help, you can just ask me.
What
This is-
were modified?
And I've got this marked up. I'll leave behind my copy of the bill. We can Xerox it.
On draft 3.2. I've had my printed out copy for a long time.
I'm sorry.
Where it was passed by Senate, so.
So that's all. Then you get to where I was supposed to start.
Section 4.
Hospital duty, section 4.
Question.
Please.
regarding The board.
Mm-hmm.
Do you think it has too much authority or has too little authority? Or is it just right?
This is a great question. I think if the purpose is really clear, this is why I think more authority would, in my mind, be better. I think we'll get to sections 5 or 6, which is about the network. I think there are so many ways now that hospitals can present information that doesn't tell the complete story about where the money is going.
Say that about a lot of things.
Yeah, and competition can take care of that when people compete for, buying. I guess we're no longer going to do that right now for buying low, inexpensive goods that we can judge the quality of. So that would be my answers. I think that I think strengthening the board's capacity to have the information it needs to understand how the healthcare system is doing. And this document is pretty silent on improving quality measurement, but I sort of decided I would include that under payment models as they think about payment models, that you align measures of quality with the payment models so that you reward them for achieving quality. Why? You only give them a share of savings or the financial incentives if they're also improving quality. So I'd lean toward more power in a market that's so more authority, and transparency and accountability, about whether they're doing it toward the goals that we want to achieve. But I may not, you look concerned, so I want to hear your follow-up.
I think in some ways you're right. I think it depends on leadership.
Mhm.
I think the leadership really is good. If it were to change,
Yeah.
it might be a little different.
No, it's a great,
Leadership's everything.
leadership is everything in healthcare, and, I'm totally
You're talking about leadership
on the board.
on the board? Or,
On board.
okay,
Well, it's also true in our healthcare organizations.
Yeah.
or
um,
country.
Yeah.
But that's where the accountability comes
It's
in.
the goal is the goal,
The goals and the.
clarity of goals, specific aims that have to be where, effective improvement is not just about the goal, let's make stuff better. It's about a specific aim that's quantifiable that you aim to hit. And that's where it really comes in. So I think we could have a long conversation about whether the governance of the board should be better protected from rapid changes in long-term political. We have a prescription drug affordability, slight digression. We have the prescription drug affordability boards that have been now launched around the country. Vinnie DeMarco is the guy who's been pushing those at Maryland Healthcare for All. They just this year, just last Friday, a week ago Friday, passed the legislation that made it apply, that it will eventually apply to all drugs sold, all prescription drugs sold in the state. But they have a very interesting structure of the board to protect it from any individual shift that has a slightly bigger board than ours. But it has the governor appointing one, the chair, the president pro tem appointing another, the House appointing another, so that the rep and for longer terms, so that you try to address the stability of adherence to those goals by balancing who gets to appoint. And we're not going to go there right now, I don't think. But I wouldn't object if you did. So I think as we talk about the planning later, I think that's the question of how to achieve that accountability, steadiness of purpose that we need. All right, on to hospitals. So, I think I wondered, was it there? Yeah. I wondered, as with the other sections or the sections on goals, and I don't know whether this is kosher in legislative work, but I would wonder if you can add a purpose to this section on hospitals' duties. And it's really about the purpose of budget development. And I think that it's really about, in order to optimize the healthcare delivery system, the purpose of budget development and approval and the budget development and approval process is to optimize the local, regional, and statewide system of hospital and other facility-based care in order to achieve the goals in section 9371 of this title. I think my idea was, I'm trying to encourage you to set up when I'm with the right, a goal toward which the Green Mountain Care Board and the hospitals are supposed to work. That then says, all right, well, now that we've got that goal, we're going to actually think about how we do our budgeting process, how we develop our budgets as hospitals, and how the board responds to those budgets in order to move steadily over time to a more optimized healthcare system. Does that make any sense at all? So then getting down into the weeds of this one, subsections 7, right just down A6, the number of employees of the hospital that they need to provide data on. You do have down here and such other information as the board may require, so you don't have to do this. But I would encourage the board and you to say it's not just about administrative expenses versus care delivery. There's all sorts of other stuff that we might want to know. So, should this include, the data needed to assess workforce adequacy? So it's not just administrative versus clinical, but how many people are in primary care? You have 8 orthopedic surgeons at this hospital? Is that too many or not enough? So I would encourage thinking about, I'm early in my career. I really focused on trying to understand what drove healthcare spending and how many specialists you have. Turns out to drive healthcare spending, and what kinds they are turns out to determine whether you get a lot of surgery or a lot of neurologic care. So I would think about optimizing workforce to meet the needs of that population. It should be FTEs, and you know where they're shared, so that you can start to have a map of where the workforce is and ask questions about, do we need more? Do we need less? And I think, I think that's and here's where I get really, and my friends on the board will hate me, so, but it's okay, I'm going to say it anyway. And the hospitals will certainly hate me. So further down, yes, it's on the same page, subsection 9 or whatever those things are called, 9 in parentheses. Proposals for way in which the hospital can support community-based independent non-hospital providers, et cetera. This is where I think it may be here. I think this is this notion of regional systems of coordinated care. And I think we need regional systems to be coordinated, integrated, maximally efficient, with some hospitals transitioning to new roles, some increasing specific needed services. And I think you should try to give the board authority, if it needs it, to require submission of regional plans jointly developed by the hospitals in those regions. Silence.
I know, what does that mean?
Oh, I'm not silent.
Shaking to get his hand up. Do you have a question?
Regional systems, that include, what would a regional system look like?
Well, we are now probably, I mean, I think we're at risk of losing what, 5 or 6 hospitals. Instead of having that happen, and Act 167 essentially proposed, the Act 167 report essentially proposed, here's how you should do it. We will require you to, we suggest you close these things here, open, consolidate these things here, share services there. I think I think that's a great idea, but having it either mandated by the board or waiting for the hospitals to do it on their own isn't going to get us to where we need to go.
No.
So asking or requiring you guys define or define the geographies around which you want planning to occur, and then the organizations within those submit to the board plans for how over the next year or 1, 2, and 3 years, they will align, coordinate, reduce, increase services in order to better optimize care for the affordability and quality of care for the residents of their regions. And then you ask, when we get to what the board's supposed to do, they're supposed to call for those things and give budget guidance that says what they expect. Now, doing all this, this is where this annual, let's do it once, wait a year, hope it gets better, and here we are again with everything going up by 3%, doesn't get us as far as I think we need to go.
So what maybe I'm not hearing you right. Maybe I am. You're talking about structural change in the delivery system.
Yes, exactly.
And would I be safe to say that a hospital would be like the center of a region, and on the outside of the hospital region would be places where people could go, like express care places and things like
Urgent care centers
where
or
they can provide the services that the hospital's now providing through emergency rooms, get them out of there and have that.
yeah, I think yes, essentially. I think the rub is in, it's, if you take each hospital service area, and this is why I dodged by saying regional, you also want coordination with the neighboring hospital service area or the surrounding hospital service. So which of us, and this was all Bruce's, this was Bruce Hamry's concept, but how do we put it into place soon so that we can optimize our system in a way that's affordable and we can get back to spending, having premiums that are closer to what our neighbors are. Is that, so this regional thing is complicated. But I think we ought to be requiring hospitals to come. I mean, I suggested perhaps the language like, and, you know, how the hospital or facility proposes to improve care delivery while reducing system-wide costs through collaboration, coordination, integration, and redesign of services with other hospitals and facilities, or through implementation of shared services agreements. Those were all in Bruce's reports. I'm sorry, Dr. Hammer's report, whatever. Trying to help put in place the process that could allow hospitals and the board to do that in a iterative learning way that allows us to reduce those costs.
And all the remaining hospitals that would be functional would have to cooperate with each other
Oh, totally. And yes,
in the planning.
exactly. No, this is like,
Implementation.
don't make me,
Yeah, 100%.
don't make me run. I'd be happy to try to help. Because I think there's some tools to do it with, but, so that's the idea of hospitals, you know, being required, expected to work together to propose. Otherwise, we're just going to lose hospitals and people are going to lose services.
That's right.
How do we task hospitals with forming these plans for their health services area or region?
Well,
How do we do that without having unintended consequences of, say, consolidation?
there's a police, someone's helping. Someone's saying, this is an okay proposal. This is a terrible plan. And by the way, we can regulate your prices. So consolidation is not going to solve your problem. You're not going to get monopoly prices we let some places get away with for a long time. So I think I mean, in the real world of doing this, you probably, you know, or the hospitals should, or the Green Mountain Care Board should, or AHS should, if they're doing hospital transformation, hire, you know, or build the system that makes developing those plans possible. I mean, if the planning process, if it were well done, you know, wouldn't wait till whenever it was, 2059 or 69. No, 2029. I'm sorry.
I was going to say,
Yeah.
really. 59 actually seems realistic.
So it could be put into that bucket of some resources there to support the regional planning that needs to take place in the development of the regional plans in a more real-time, lively, iterative way that's not dictating. It's not having the government tell people how they should do things. It's having the government facilitate the development of things they want to do and are willing to do.
It sounds like it's basically the next iteration of 167 transformation work, but that we're putting in the accountability piece here. Because, you know, AHS has hired a firm to do the work and is starting to work with hospitals. I think there's a meeting coming up to get us feedback on that, but there's no, like, we didn't put anything in Act 176 to have accountability on that next stage.
Yeah, and I think I'm trying on the side to help AHS think about how to make that process as successful as possible.
Yeah.
And it does require facilitation to do it really well. And it's not, you know, asking a hospital to say, tell us what you're willing to give up.
I know.
They go, nothing really, thanks. We're going to stay open. So you have to help them and developing a proposal that they're not committed to, but they get to criticize, changes the way they think about it. Let them criticize the draft until whoever's the facilitator says, oh, I guess this is as far as we're going to take it. You want this or you want to close?
Right.
I mean, this was first used at Camp David. this process of negotiation based on a single text. That people criticize, they don't barter for, more money or whatever. Sadat and Bacon complained about the draft 23 times.
Yeah. Well, we need to move them all
Yes.
faster, is the issue.
But I really think if you approach it a different way and you say to the hospital, all we're asking you to do is, if you're in a network, we're asking you to deliver the services in a different way.
Mhm.
That's all we're talking about here.
Yeah.
And in that different way, it's going to cost less
Yeah, I
to deliver those services.
totally agree with you. Yes. And the question is how to get them to engage in sharing enough data that we know which services really are least expensive and most expensive for them with their collaborators. And some of the stuff is probably going to happen at DH, should happen at DH, but some of it should come or UVM, and some should come back to the communities.
Yeah, right.
But this is the design challenge, the redesign challenge that and I think the budgeting process is probably where it needs to sit, with someone pushing, and so that's the language I've tried to suggest in these edits to make it a multi-year planning process and iterative planning process for the board when they can submit their preliminary budgets in January, target budget, initial thoughts, and they get feedback. Of course, the board needs more staff to be able to do that, but I don't think we do this without adequate technical and smart facilitation on the part of board staff to make it happen.
Yeah, I was just thinking, it's all well and good, what you're saying, looking at the data, analyzing it, and making decisions. But there's also other issues involved, such as geography. From
Very much so.
From one place to
Oh,
another.
yeah.
That also should be considered as well.
I think that's what this is. I'm trying to propose. If I didn't, it's being sensitive. Newport's a very different place, unless people want to move to Canada. But
We're almost there in Newport.
so absolutely, it takes geography into account. I mean, the one place I was not excited about the recommendations was like close Newport. Are you kidding me? Or what? How do we have? We got to have access to emergency care, and so. But that's exactly.
Oh, Wendy.
I just have to say, like, I get that, and I have to think that we have to come up with something else, because I don't want them to close either. I really don't.
Well, I don't want to see anything close.
No,
With being realistic.
exactly.
Yep.
The last night on the news, I watched this guy have a heart attack on a mountain, and they resuscitated him. I think it was up in the Northeast Kingdom, and not Dartmouth, it
Yeah.
was UVM.
Helicopter.
Helicopter
Yeah.
got him into UVM Medical Center, literally put a stent in, kept him alive. He was there for 2
Yeah.
weeks and got home. He was an out-of-stater too.
I think we should be totally open to trying to redesign care. I mean, EMS.
Absolutely.
I was told by a close friend who is an emergency physician, Elliot, if you don't talk about emergency medical services and what they need,
Exactly.
you're failing me as a friend of mine. So I totally agree with you.
You're right, but also helicopter service is not available 24/7 due to weather
But
conditions.
paramedic, a good paramedic team, a well-equipped ambulance with its paramedic services can do a lot. So yes, a 24-hour emergency room everywhere in the state, just so that you can go to the emergency room instead of go to a well-manned, radio-connected, EMT, paramedic staffed, and physician coordinated and communication. Good point.
I find it funny that every time you call your dentist and you get an answering machine, they go, "This is an emergency, please come hang up, dial 911."
Well, we could use statewide 211 or 111, which is nurse call lines that would keep people out of the emergency room.
But here's another. You need some of those services, to take somebody off the mountain. You can't get them to UVM, but you have a local hospital, need those services at that hospital. I'm not a doctor, okay, but to stabilize the individual long enough so that you can eventually transfer them to
Absolutely.
UVM or Dartmouth. I mean, all these things have to be taken into
Yeah.
consideration.
I agree. No,
Spider web.
when I have my heart attack, I want someone there to take care of me.
Yeah.
At least it's time for me to go, in which case.
That's called using the hospital for what it's set up for.
Yes.
That kind of circumstance you're talking about, that's where you need the hospital. But the cost of that hospital, the way we're operating it now, is astronomical.
Well, that's why we need reference-based pricing.
Or other tools to help them decide what to do rather than just, anyway,
Okay.
anyway, on to section 5 budget review.
Yes.
All right. Basically, this is I've sort of, again, I might start with adding a purpose about system optimization, just to drive it home that budget review process is to help system optimize. And I've already mentioned this, that, the underlying issue is that a simple annual budget process, the way it's structured now, may be a barrier to making things happen that we need to happen more quickly or more slowly, or that are not a rush. 3 ideas. Maybe it already has authority to do this, but authority to require short-term budget adjustments in the face of changing circumstances. Medicaid cuts. But also require long-term planning. That's the other thing I've mentioned already. And these are, I did not try to write a lot of specific language, but the ideas are, one, that the board may offer longer-term budget guidance, may require interim adjustments during the year, and may require longer-term budget plans for service line changes. Something like that we already talked about as part of this regional process of. There's a weird thing, excuse me, on subsection 7, somewhere down below. It's in subsection B, in conjunction with budget reviews, the board shall, number 1 was review utilization information, but you go down to 7, and the draft calls for excluding revenue derived from primary care, mental health care, and substance use disorder treatments when determining a hospital's net patient revenue and total cost of care targets. And I worry I worry that maybe that requiring or offering them permission to do that may be a better step forward. So giving them the flexibility to do that, but they may want to exclude other things that are, fixed costs of emergency room services. So they may want to, I just think only, if the only tool they have is to set total revenue caps and can't do anything inside it, that's the budget guidance, the more detailed budget guidance that I think I'm calling for, which they need staff for. But if you can't look inside the budget, then there may be some things that you want to keep outside that preserve and squeeze the reference-based pricing to push down on the things that you do want them to do something about. Let's see, I think it's subsection 13, where the bill only calls for hospitals to provide information on administrative costs as defined by the board, and including specific amounts on the marketing and advertising. I think there are a lot of other costs and ways that money flows through hospitals, especially big ones, that you want the board to be able to identify and go after. So there's an article that was published in the National Bureau of Economic Research on something called profit tunneling, which is a hospital is going to lease a building. So those rental costs, those seem like obligatory things that we have to do. But it's a way for hospitals to give money to a for-profit subsidiary or to another for-profit entity, which pulls money out of the hospital and gives it to this other entity. So I would try to think about any place, language that allows the board to seek information on all financial activities that may influence the affordability and efficiency of the organization and transfer of funds from commercial ratepayers and Medicaid to other entities outside the healthcare system. I think I mentioned this last time I was here. The woman who ran Washington State Healthcare Authority hired 3 forensic accountants to go after, to examine Providence hospitals, the Providence healthcare systems, ways of hiding money in offshore accounts and then bringing it back and taking Washington State ratepayers' money outside the state so they could expand their monopolies in other states. So give them the tools they need we saw what happened at UVM. We just need the ability to do something about it. So, I think I have some specific language on that. And any other information the board deems necessary to understand the revenue and income flows that may affect the cost of care for some payers.
Like endowments, I'm sorry.
It's so interesting. I think I'm just more and more curious about how those endowments and non-operating, investments are funded. We know they were funded by us. But what they do with them, we ought to be able to have some say on that. Like maybe if healthcare costs are so ridiculous, they ought to be able to withdraw from their investment or other reserves in order to help fund shortfalls in Vermont spending so that consumers can have lower costs. If you're Harvard, you can afford to. Probably not for long though. But understanding where it goes and where it's been and where it is the first step toward being able to have a choice about how you pull that money back. I hear my hospital colleagues getting angry. How dare you say that?
Would you mind, by the way, sending us what you said you were reading on hospital, on price or tunneling?
Profit tunneling?
Profit.
Happily send you profit tunneling.
I'm finding it, but all I can get are abstracts.
Oh, yeah, no,
I'm not a paid
I
member.
will certainly do it. I think this actually came to me via Elena, but I can find the article. It's somewhere on my hard drive, probably. Then the last little bit. Of one of these subsections, A, B, there's a sentence that begins, global hospital budgets established pursuant to this section shall include Medicare to the extent permitted, but not include Medicaid. And I think this is around the complicated issue of global budgets. And the goal being to try to reduce their overall costs so Medicaid doesn't pay too much. And our ratepayers don't pay too much. So, I believe that, as I mentioned already, all payer global budgets are one way to set caps, a fence around total hospital spending. And it would obviously probably have to be done in collaboration with Medicaid, and everybody agrees on it. And I don't know how to write the legislation around that. But is there some way of modifying the language that it could be done through joint agreement to have Medicaid implement the needed changes by rule that would allow us to have, especially if we got Medicaid able to join this at some point, that we could have all payer global budgets. So that just seems to rule it out the way it's written there. And I think I'm winding down. The last bigger issue, but it's also for the board, and I mentioned this already, I think payment reform needs to be part of this whole package. And I have not thought about whether they've got so much authority to do that already. You're preserving the assets of the ACO already. And if I were to propose a path out of one of the elements of moving more rapidly to reduce costs, would be to implement statewide the Medicare Shared Savings Program, which is now covering 50 to 52 or 3% of Medicare beneficiaries. Peter Pronovost describes saving 40% on his 800. He's got more people in his ACO than we have in Vermont. 800,000 members of his ACO, and has reduced costs by 40%. And I'll push that outside this, and you don't need to include it in the bill, but I think there's just this window of getting the incentives aligned so that we do less unnecessary stuff. And then just last, if I can, I'll make a few comments about, since I'll be in California next week, hard to join it, on the healthcare delivery plan. And it's the bigger picture. It's really trying to build this as a system of continuous improvement. Where the planning process, it becomes a focus on the planning process rather than a plan. A state plan sounds to me like, I'm sorry, Soviet Union in the 1950s trying to figure out how many paper clips to make and how many bicycles. I think we want a planning process that identifies the drivers. And this is written in many other states' legislation, total cost of care targets and what their state agencies are supposed to do. Identify the drivers of poor performance, identify the opportunities to improve, and then make specific recommendations for what everybody can do to address these each year. And I don't think you should wait until 2029 to have any recommendations. I think whoever is thinking about the future of Vermont's healthcare system, and for hospitals, it's probably the board, and for primary care, it should be AHF probably. What can we do to make these things stronger next year and next year's legislative session? And they should come to present that report on that. And that's aligned with the language I think I've sent in and suggested to Chairman Black on the primary care task force. And you could make those ideas more general, but the idea of a report that's annually looking at the performance of the system and what we can do to make it better. That's the process I think we should have, not telling AHS to go develop a plan by 2029. Beating you all up.
Any other questions? Alan, did you have a question?
No, I was just curious. We heard a speaker before talk about doing maybe in increments of public employees and teachers. And what's your feelings on?
Reference pricing that way? Well, I worry two concerns. One is, gee whiz, we can't afford to have hospital costs go up much more. Why not move as quickly as possible to do it for everybody? Because I think it just is, I think the experience in Oregon was that they couldn't detect an increase in spending elsewhere, but providers are going to stay busy. And so you reduce the prices over here. They're probably going to be able to just say, Elliot, I think you'd need that MRI in 3 months, not in 6 months. We want our revenues to stay high. And that's the problem with reference-based pricing anyway, because it's subject to the volume offset that comes with price controls. Which is why the global budgets or a vigorous budgeting process that says hospitals, let's get together and do this more quickly and more effectively, just with our current budget process before we get to global budgets, which are going to take a little while to figure out if we did. Does that answer your
Yep,
question?
very good, thank you.
If we set reference-based pricing that an MRI is 100% of Medicare and that's it, do you think your doctor is going to order you an MRI in 3 months instead of 6 months?
Well, they open up the Dartmouth Hitchcock MRI pretty early in the morning. And if they lose the revenue and need to meet their budget that they've set for that year, I believe they will figure out ways to make sure they hit their revenue targets. That's the way how healthcare behaves. And it's been, all that effort, you may have remember when they were trying to control physician prices, the sustainable growth rate formula where, let's squeeze what we pay physicians under Part B. There was a clear revenue, a clear offset. That is, the doctors all decided to do more stuff in order to maintain their incomes. It wasn't 100%. And I don't remember exactly what the number was.
I have a question, kind of unrelated, but also related. And I thought you would be a great person to ask since you're at Dartmouth. Now Dartmouth Hitchcock.
Live in Vermont.
Okay. You're familiar with the Dartmouth Hitchcock Hospital. You've seen it before. Yeah. A number of years ago, they made some pretty significant cuts. And I'm wondering, how did that go for them in the end? Did their quality suffer?
My understanding was they were able to do with consultants, were able to do a fair bit of work to clarify roles and responsibility and lines of authority and eliminate, many positions that actually had no adverse effect on quality and improved. It was mostly administrative positions. And reduce their costs substantially through what we hope that the liaison, is that the right name?
Yeah, I think it's a liaison now.
Liaison can help UVM do. Does that answer the question?
Yes, I was just wondering if you would tell us of the experience of what they went through and if it affected.
I know, and I've talked to several people, no evidence that it led to decreased quality or access. And we heard in his presentation, or was in the Becker's Hospital Review, Sondovos work with University of Cleveland hospitals, that they took out 250 million in healthcare costs in 1 year from a system that's twice the size of Dartmouth, UVM. So if they did that in 1 year, we should be able to get 125 million.
I think we're constantly told that, if hospitals are forced to make cuts, that it's going to lead to these doomsday and a hospital in a region very similar to us and a hospital that we utilize, Vermonters utilize, did have to go through this process.
Yeah, and did fine. And it's not easy work. This is the lesson of Intermountain, where they achieved the goal of keeping hospital costs or healthcare costs for their whole system, the consumer price index plus 1%, which is way below where anyone is in the growth of healthcare spending. They had to take out a lot of avoidable costs, and they improved quality, which kept people out of the hospital. And were helped by having 30% of their revenues come from the health plan that they owned, which we've thus payment reform.
Thank you. Thank you for coming in again.
Yeah.
And I'm sure we will see you again. although enjoy California.
It's a short drive, go take care of grandchildren.
Oh.
So my daughter gets to go have her 40th birthday in Paris.
Oh.
Good thing. But Nova Scotia would be a fun place to be.
Yeah.